Good evening. You guys are really good at getting quiet. My goodness. Yay. This is exciting for lots of reasons. One, of course, we're excited because we have such great physicians up here tonight to share the vision with you all of what we're creating, which is going to be opening in just a few months, right? We're going to have an amazing new hospital on our campus dedicated to caring for patients with neuroscience. What's also exciting is to see so many people that we know and that we interact with and that have been part of this process over the last several years. Some of my slides go into what our process was. There are too many very important people to recognize tonight. So in lieu of that, I'm going to pick three. Three of the most important people, maybe five. We'll see how it goes. Of course, I want to thank Chris Howard, our president and CEO for Sharp Healthcare. Brett McLean, our Chief Operating Officer for Sharp Healthcare. And the third one is going to surprise her, and she hates being recognized, but I want to recognize Mary Ellington. And obviously, so many people know Mary. She absolutely hates attention. So let's give it to her. Just a little bit. Mary, really, thank you. It's so, I was so happy to see you here tonight because really much of what we're talking about is the vision that you've had for decades before it was even a reality. Mary started, of course, at Grossmont, started in a nursing unit and really developed the entire neuroscience and orthopedics program for Sharp Healthcare over the course of several decades. She won't let me tell you how many, but there were I said several, not seven. It may have been seven, but I don't think so. It was maybe like 4. So, Mary, thank you so much. We definitely appreciate it. And she still continues to have passion and love around this project and put dollars around this project as a donor as well. So my name is Scott Evans. I'm the Market Chief Executive Officer for our regional hospitals. I've been with Sharp Healthcare about 10 years. Actually, it is 10 years. Starting at Grossmont Hospital when we really started this vision of creating this service line probably 4 or 5 years ago. The slides will tell us exactly how long that was. And to see it to come to fruition is just pretty darn amazing. I'm also responsible for Sharp Chula Vista and Sharp Coronado, as well as Sharp Hospice Care. And a lot of these physicians are working at all of those different places. Dr. Cockerham, we just saw that you have now privilege coming at Sharp Chula Vista. So that was exciting for all of us. All right. When we set out to talk about neurosciences and create something fantastic, we wanted to create the first hospital in San Diego that was totally dedicated to the care of patients needing advanced neurosurgical, neurological, and comprehensive spine expertise in a single center of excellence. We actually set forth to do that in a way that recognizes accreditation, recognizes high quality work, recognizes us for the standards that we set within the community. There was a reason that we did it, and we'll get to that part about why did we just decide that we would do it. And it's a one that's well based in need for the community, as well as potential to really be accretive to what Sharp Healthcare is doing, and specifically taking the patients that Grossmont has already had for years and really elevating the level of care. Grossmont's never had a shortage of patients. I don't know if you know that or not, but there are a lot of them. I think between Care Clinic and the emergency room one day last week, we had more than 500 that came in. That's busy, by the way. All right. This is Sharp Grossmont today, 118,000 or more ER visits when we add in visits to our walk-in part of Care Clinic, which is now called Express Care. Well, that might be an announcement, but it will be called that. Lots of hospitalizations. This is my favorite part because we have about I know we have more beds than that, Rena, but we have about 512 beds in use right now. We will have 562 very soon when we add back in those 50 beds that are going to be created by the opening of this fantastic hospital. We have more than $1 billion in annual revenue. So this is part of the big hospital club in terms of really being successful, and that's up about 100% over the last probably 8 years, I would say. So pretty exciting. We are a district hospital, which brings me to my two last recognitions. Where is Bob Ayers? I see Gloria Chadwick. Gloria Chadwick from the healthcare district. You can't point that way. You're right there. Oh, you're pointing to Bob. And Bob Ayers, who is also from the healthcare district, the president of the healthcare district this time. And we thank you for your support. This is an investment in your hospital. Because the taxpayers are the ones that own the buildings and what we do at Grossmont Hospital. And Sharp is just a proud and humble partner to be able to operate this wonderful asset for the community. That community is 750 square miles, so it's not small. It's I still, even though I've been 10 years, I still don't know all of San Diego, but there are cities out there, way out there in the East. We take care of them. We take care of those patients. I'll leave it at that. Kind of accreditation and recognition has been our guiding operating philosophy over the last 10 years. When we really wanted to set forward to be high quality, really high quality, we thought that maybe the best way to do that is to seek external validation of the work that we do. Have experts come in and recognize the work that we're doing and hold us to the highest standard. So while most people don't like surveys and don't like accreditation and don't like the Joint Commission, it seems like we're constantly inviting them in to say, look at us, look at this, look at what we're doing. Most recently, I think it might be in someone else's slide, so I'll probably steal somebody's thunder. No, I don't think so. I don't think it is in the slide. But we just received, well, today, we received our reaccreditation for our Comprehensive Stroke Center. Just got that news today. Full accreditation. I think this is like the third time, Mary. You would remember, too, how many times we've been doing that. Third time, Rena says. But also, we are now the second and first community hospital in San Diego to receive designation by the Joint Commission for spine care and have our spine care recognized by the Joint Commission. So that's another thing. We're building a brain and spine hospital, so it's nice to have brain accreditation and spine accreditation in there before we get started. And then lots of other things. We've been an A hospital for so long that they decided to make up a new thing called honor roll, or what is it, Rena, now? Straight A's. We're part of the Straight A Club because it's been like 8 or 9 times in a row that we've gotten only A's, and so that's good. Lots of things here. All right. This is certainly, we'll call it Mary's vision, years in the making a reality happen. One, why did we do it? We wanted to fill a gap in care. Sharp is certainly going to be home to the first fully integrated comprehensive neuroscience hospital. But when we start looking at where patients were going, you're going to see, I'm going to introduce you to the term outmigration. They were leaving. So we're going to talk a little bit about that. Of course, anything we do is powered by the Sharp experience, and we definitely are a community-based hospital. We call ourselves the most community of community hospitals, and we serve our community and beyond. And our community, as we become experts, guess what happens to our community? It gets larger and larger and larger because they want to go to high-quality institutions, and so they travel from farther away. I think, Dr. Travacula, you have a patient coming from Costa Rica that found us and wanted to come to us for a procedure that Dr. Travacula is doing. All right. This is about outmigration. This is the call to action. Why are, in 2020, why were almost 10%, 8% of the people leaving the area for really complex neurosurgical care? And where were they going? Well, they were going to Brett in Arizona, which we put a stop to immediately. But they're also going up north, and they're still going there, right? We're still seeing that happen, but we're going to change the course of that a lot. You can kind of see, oh, sorry, you can see there's Brett over there by Phoenix, and then they go to Los Angeles and they go up. This is a growing service line. It's growing by population, but it's also growing by the incidence. And you can see that by 2028, all of these areas, which are cornerstone to what we're doing in the neuroscience program, are going to be growing. This is a call to action for us that we need to be prepared to take care of our community's need. And this was how we got there. In 2020, I'll never forget, it was Valentine's Day 2020, because I've said this many, many times. While people were thinking of hearts, we were thinking of brains. That's a good joke, guys. All right. Valentine's Day, February 14th. You get it. It's just not funny. All right. So 2020, Comprehensive Stroke Center designation. Ryan and I were there, right? And pretty excited about that. Mary was again, one of the folks that led us in terms of doing that. And, Mary said, don't worry, we'll get it done. And in fact, she did. And now, here we are 3 accreditations later. The very next year, because we didn't wait, we actually got a project approved that was to renovate the rehabilitation unit. And then that it was the right dollar amount, everything was good, but then that really changed into, well, let's just not renovate the rehabilitation unit. Let's add on a progressive care unit to it. Let's add on an ICU. You know what? Upstairs, we should put in a clinic. And I sometimes refer to that as the story of stone soup, which, if you're familiar with that story, is where someone comes and they have a rock, and they say, I can make the best soup with just a rock, and there's a rock in a bowl of water. And then they start saying, but you know what's really good? If you add a little seasoning to this, it's going to make it good. And, then the people go and get the capital off the shelf, and they start investing in it to create something really fantastic. In 2022, we really started heavily on physician recruitment and specialty program development along the way. This is where Dr. Razadeh probably started thinking about joining us, and then he got an appointment to meet us a year later. That's the story you tell, right, Dr. Razadeh? That you have to take him out for a drink. He'll tell you that story. Then 2023 launch of MRI-guided focused ultrasound and our neuroscience clinic. And then in 2024, acquisition of a robotic spinal and cranial system and Joint Commission spine surgery certification. So pretty exciting. And then, of course, now this year, the opening of this great hospital. And here it is, state-of-the-art facility. We're hiding this lady's shoes because in the picture, they put her in like moccasin open-toe shoes, and all the nurses were like, she can't wear that in the picture. So we put a picture over that. But you can see the waiting room, the gym, an ICU, state-of-the-art ICU, and state-of-the-art med-surg. When we're done, we're going to have 50 beds, 18 neuro rehab, 16 neuro ICU, 16 progressive care. And in the neuroscience outpatient clinic on the 2nd floor, this is a multidisciplinary comprehensive center, 13 exam rooms, 2 treatment rooms, 2 nurses stations rooms, and of course a little conference center. Very exciting stuff. And this is exciting. Who has missed, anybody missed this announcement already? And why are we bringing it into here? Sharp Healthcare is the official healthcare partner and official health insurance partner for San Diego's newest Major League Soccer team, the San Diego Football Club. That is significant because we have named, of course, the Sharp Healthcare Performance Center, and the Sharp Healthcare Performance Center and Sharp Healthcare, our goal is really to revere both as premier centers where athletes and regular folks that aspire to someday be athletes or maybe spend more time on the couch, but also want to yell for a good game, want to come in and be treated by the best of the best. And that is our goal. We will be creating, of course, a performance. I think I'm going to use your name, Louise, because I liked your thing today that you said in business development. We're thinking about what are we calling our new sports medicine component, and Louise said human performance, like a human performance type of service line. I kind of like that, so we'll think about it. So what's cool is, of course, our hospital for neuroscience is going to be a big part of that. Right? It's going to be where a lot of the expertise comes from. We're gathering expertise all around Sharp Healthcare, from our medical groups, from all of our hospitals, and we're building in that service line excellence into the brand that we already do. But make no mistake, a big part of what we're going to be doing, especially so close to our performance center, Sharp Grossmont Hospital for Neuroscience is going to play a big role in that. The partnership will highlight Sharp as the leader in the space by treating world-class athletes while maintaining strong foundation for serving the community. And you'll see that these two organizations, why they came together, was really to focus on the community. You're going to see lots of community engagement. So very, very cool stuff. And it's not going anywhere. Let's go one slide up. I'll just wait. All right. This even goes to talk about forming and fostering and ensuring our relationship with the community. We want to certainly form the right partnerships that allow patients to stay local, not do that out migration. We want to foster collaboration with community physicians. Many are here tonight with specialists and specialists from other disciplines. Where's Dr. Jabaji? I was talking, Dr. Jabaji and I were talking out in the lobby, and he's like, what'd you say? People are excited about this. Like, people are here because they're excited about the good work that we're doing. And he's absolutely right. And so we're going to see that. We're going to be the referral centers where we're able to receive these patients. Of course, we want to ensure equitable access to high quality neuroscience care by implementing all of our policies that promote inclusivity and reduce barriers to care. And that's really what it means to do business in San Diego and take care of our patient population. These are our amazing physician speakers tonight. Now, Dr. Viets, before you send me an email, it's alphabetical. And so this is the way we set it up. It was a different way, and it was a different way, and it was a different way. And I told the team, put those doctors alphabetically, please.
I'm just happy I look better than I do in real life in that picture.
You all look great. So I'm going to turn it over to our first speaker, Dr. Ryan Viets, and it's appropriate that Dr. Viets is our first speaker because Dr. Viets at one time was a one-man show.
That's right.
Really as a interventionalist and in our radiology department, and really we could not have gotten comprehensive stroke center designation without him, because you need at least one person that can do the job. And he was the one that we started with. We had another one also, but he was the one. And from there, we've just really kind of grown across all kinds of folks. So without further ado, I'll turn it over to my friend Ryan.
Thank you. So I don't need this, right? Yeah, because I have a microphone. Thank you, Scott, and thank you. Good evening, ladies and gentlemen. And yeah, it's been a long road, but it was a fun road as well as we grew throughout this process. So I'm going to talk about stroke care at Sharp hospitals, at Sharp Healthcare, the way it is now, kind of where we're going in the future, and also importantly how we integrate the care amongst our various hospitals. So as we talked about, Sharp Grossmont is a comprehensive stroke center, and I remember that Valentine's Day because that was the last big group I was in for about a year and a half, since the country shut down about a month after that for COVID. So that was a good accreditation. Sharp, Chula Vista, Coronado, and Memorial are all primary stroke centers, and we plan to increase the certification level of probably a couple of those going forward. So quick facts about stroke. Some of you know this, but for those who might not, there's about 800,000 people a year who have a stroke in this country. Some of those are a second stroke, but many are the first stroke. Most strokes are due to a lack of blood flow to the brain. So either a large artery is blocked by a blood clot, or There's hypoperfusion, so someone goes into cardiac arrest and doesn't get any blood flow to the brain. And then about 10% of strokes are due to bleeding in the brain from a ruptured brain artery or from a hypertensive bleed. So where do we focus our areas of stroke care? So there's a few things that we have to do, and it starts with community education. Because if we don't educate the community as to the signs and symptoms of a stroke, it's not going to matter because the patients aren't going to show up at the hospital. And we have some good literature on this, that at least half of patients who might be eligible for therapy for some of their large vessel, large clots blocking artery in the brain don't show up to the hospital because they either don't know the symptoms well enough to come in, they ignore the symptoms, they go to sleep instead, and they don't get the treatment in a timely fashion. So a lot of what we've done has focused on community education. And then EMS protocols too. The ambulances and the medics have to be able to recognize, and there are some scales that they can use to do this, or some triage instruments, but they need to be able to recognize when someone's having a stroke so that they can bring them to the appropriate hospital. And in San Diego, this is still a work in progress. So it's not, some patients wind up where maybe they're not going to get the most or the quickest care, maybe they have to be transferred again, but we're working to change that. But that's a big part of the process is the EMS protocols. The emergency department protocols, we've worked on this for years, for nearly 10 years to get our protocols to the place that they are now at Grossmont. And at the other hospitals, we've been working on it as well, and they continue to get better. But it doesn't matter if the patient comes in with the stroke, but we don't recognize it in the ER, and instead of getting the head CT to look for bleeding or to see if there's any damage to the brain, within 5 minutes, it takes 30 minutes, and then to get the CAT scan angiogram to look at the blood vessels, it takes another 30 minutes. We're wasting time. We know that time is brain, especially in the ischemic strokes where there's a lack of blood flow. Time is brain. And so we have to move quickly. So we've spent a lot of time and effort optimizing those protocols. And then advanced stroke care. So obviously we spoke a lot tonight, and we will continue to speak about the Neuroscience Hospital. That's a big part of it. Aftercare, ICUs, nursing care, biplanes, so really fancy x-ray equipment that can do a lot of these procedures in a quick, fast, and safe manner. And that's the last piece. So I thought we'd kind of show maybe 3 case examples to give an idea of how we integrate stroke care in Sharp Healthcare. So the first is a 46-year-old female. She was at work. She had no medical history. So young lady, young kids, and all of a sudden she was at work in the morning, maybe 9:30, and she got a worst headache of her life. Super severe headache. She'd had migraines before, but nothing like this. Immediately started vomiting. She was still able to talk, but she knew something was wrong. So she went into the emergency department at Sharp Memorial because that was close to where she lived. They did a CAT scan of her head very quickly because the doctors realized something was seriously wrong, and they found this, which is called subarachnoid hemorrhage. So that's bleeding in a certain space in the brain, and usually that's due to a ruptured brain aneurysm. Not always, but usually. They did another scan to confirm that indeed she had an aneurysm. So right away, a couple things happened, and this is one of the ways we integrate care. The ER doctor got on the phone. He called my service, and he also called neurosurgery and the ICU doctors at Grossmont. We quickly transferred the patient over to Grossmont, and she went first to the angio suite, where we found, I don't know if this has a pointer on it, but we found an aneurysm. Uh-oh, it does, but it doesn't like when you press that button.
Don't you work with expensive equipment?
Yeah, no, maybe you should stop me. Okay, so. All right, I'll try one more time and then.
The laser pointer actually doesn't work on our screen here, so you just have to point, sorry.
Got it. So here's an aneurysm, okay? And this is what ruptured and caused all that bleeding. And then one of the neurointerventionists was able to put some coils in there and treat it pretty quickly. And so that'll stop any additional bleeding. And then shortly thereafter, the patient came back to the ICU. We woke her up, but she wasn't really waking up very much. She was getting sleepy. And that's a common thing that'll happen because the brain, the fluid that's circulating around the brain starts to get clogged up in a process called hydrocephalus. She started to get sleepy, and so our neurosurgeon on call came in quickly and quickly put a ventriculostomy tube through her skull into her ventricles to drain off the fluid. And that happened, almost instantaneously. And then she recovered in our ICU. She was monitored very carefully for complications that can occur. And 3 weeks later, she went home. And this was in October, and she's back to work now. We just saw her in clinic. She's back to work, and she's made a full recovery. And most importantly, she's there for her family, right? This is a person with young kids with a lot of life years ahead of her. So that's one thing. And then what about this guy? So this is a 52-year-old male who was last seen 2 hours before he showed up at the ER, and he couldn't move his left side at all. And he was neglecting, so he wouldn't look into the left, he wasn't paying attention to the left side of the word. He was slurring his words. Scans were quickly done at Sharp Memorial. Now, what about this patient? Did we have to transfer him to Grossmont? And the answer is no, because this is a fairly straightforward case where there's a clot blocking a major artery here on the right side of the brain controlling the left side of the body, so he's not moving his left side. So the interventionalists at Sharp Memorial, because they can do it much quicker than we can transfer the patient over to Grossmont, are able to quickly take that clot out. And you can see now the vessel is open and perfusing normally. And this was done in about 20 to 30 minutes. And this is for those who don't know, this is a certain type of MRI sequence that shows stroke, and the white areas of the stroke. And there is some stroke, but it's quite small. And he also made a very good recovery. And the last case I'll show you was a more complicated patient, a 67-year-old male had a history of high blood pressure. He initially presented to Chula Vista, and he had a stroke scale of only 1, meaning that he had very mild deficits. He was a little bit dizzy, but otherwise doing fine. But he has a very interesting scan, so his arteries in the back of his brain are open, the main one, the basilar artery, but in the vertebral arteries, which lead into the basilar, he's got a plaque and he's got some clots. So even though there's flow in the basilar, we were very worried about this man, and so we transferred him up to Sharp Grossmont, where there's a little bit more experience level in terms of the neurointerventional, and there's also slightly more advanced equipment. And sure enough, about an hour after he arrived, he started getting real sleepy. And he wasn't able to wake up at all. He wasn't really moving his extremities. And so we took him right to the OR, to the angio suite, and we did an angiogram. And this is that vertebral artery. So it ends up here in a clot, a big clot that has now gone up into his brain. And so this situation here is not compatible with survival. So we were able to go up, suck out what was there of the clot, but he still had this lesion here, which was the culprit, and that's a hardening of the artery, an atherosclerotic lesion that got activated over time. We watched it for a while, and this is where the experience comes in and why it's very important to have hospitals that have really optimized their processes and that do a lot of these cases, because when you do a lot, you realize that if you leave it like that, it's going to clot again. We watched it for a little while. 5 minutes later, it's getting worse over there. And so we ended up putting a stent in his head to open up that artery. And he had a bigger stroke than the other guy, but I saw him in clinic a few weeks ago. I mean, he's also doing well. So that was another good save. And it comes from really integrating care amongst the hospitals. So we're very excited for things as the neuroscience hospital opens. We expect outcomes in patient care to get even better and better, and we're excited there's a lot of hard work ahead, but we're excited for the journey. And I'll turn it over now to one of our wonderful spine surgeons, Dr. Ramin Razadeh, and he will speak to you as well.
Thank you. Good evening. So I think, Ryan, it's amazing talk, but one thing he didn't mention, how these guys do this neurosurgical procedure is amazing, right? So they make an incision either in your wrist or your groin, and they're able to do all of this through that. It's pretty amazing, rather than having to open up your skull. I mean, I'm just a spine surgeon. I don't do that kind of stuff. It's kind of crazy, but nevertheless, it's pretty amazing. So talking about neck and back, what do I do for a living? So why spine health matters. So I want to talk about what we do at Sharp Grossmont and how we treat it with our different surgical techniques as well as the technologies that we have at the Grossmont Hospital. So highly prevalent. 80% of us will have some sort of neck pain or back pain sometime in our life. So it's a huge, significant portion of disability that we experience worldwide with neck pain and back pain. What do we do in our practice? Dr. Paul Kim, my practice partner, is here. 94% of the patients who we see get better with non-surgical management. So you give it time, you do physical therapy, you do acupuncture, you do injections, it gets better. And so many of us have woken up one day with neck pain, back pain. You don't get worried about it. As long as you don't have any neurologic deficit, it gets better on its own. Only 6% of patients require surgical intervention to address the back. So when that 6% comes through, we got to get that right in how we address that 6%. The common conditions we treat are degenerative disc disease. How when the disc wears out and is wear and tear of the spinal disc. We treat herniated disc. And each one of these, I'm going to give an example of what it really looks like. So herniated disc, like a jelly-filled donut, the disc is popped out of place, it's putting pressure on the nerve, and that's what gives you sciatica. Spinal stenosis, that's an age-related problem. The canal gets smaller. As the canal gets smaller, there's a technical term for it, or a regular layperson's term called a shopping cart sign. So as we go in the store, a lot of people bend over. And the reason why they bend over, they physiologically open up the area for the spine. And so that's spinal stenosis. Then when you extend back up, it tightens up the area for the nerve. Spondylolisthesis is when there's slippage of the bone. When there's slippage of the bone, it can put pressure on the nerve, and that's what we call, grade 1 or 2 spondylolisthesis. Complex deformities of spine surgeons we treat, but I'll defer that to Dr. Jaswani on the next phase, and he's going to talk about some pretty interesting stuff that he's doing. So technique-wise, how do we do this? So huge fan of either you do it minimally invasively or open. Now, certainly on the right slide, we've done all of these as neurosurgeons, spine surgeons. We do this all day long, and some disease processes mandate it. You got to do the procedure on the right just because of the underlying problem. However, my practice is the left slide. I love small incisions. I love incisions that I can get to do what I need to do with the least amount of trauma to the area, less amount of blood loss to that area, and because it does that, it decreases the infection rate in that specific area. Now, the technology that we have at Grossmont is amazing. And that's what makes us the center of excellence for spine surgery, for neurosurgery. So we have robotic surgery where we can have a robotic arm that can help us assist putting in those screws. Because when we're putting in pedicle screws, the margin of safety, it's quite low. If we're putting a screw like this, is great. You put it too far this way, you can paralyze somebody. So you can't go medial and you can't go low. So if you're going to miss, you got to go high and out. But the now robotic arm helps us do that. The navigation also, it's a GPS for spine, so it allows us to place these pedicle screws in specific orientations perfectly to minimize the amount of potential complications. My surgical preferences, and I think this is what we have at Grossmont that really sets us apart from any other hospital in town to become a destination center at Grossmont. I have several different passionate things that I do for spine surgery. I love motion preservation surgery. When you have an operation, when you can do something, when you can take the pressure off the nerve and you can maintain the motion of that segment, whether it's in the neck or the back, it's the most rewarding surgery I feel that you can provide for a patient. I love game-changing technology. I'm going to go through a procedure called a barricade, which you put in a device into the spine. So typically when you have a herniated disc, you do a microdiscectomy, but it's a gel-filled donut. Rather than just keeping it be, you can put a device in there that prevents another piece coming out. Another game-changing technology is the navigation that we use, the spine, the robotic that we use. It's incredibly important for these complex surgeries to have a device to put in that optimizes the chance for success to make sure that screw is done perfectly. I love minimally invasive surgery. Minimally invasive surgery is critical because if you can get to the goal of what you need to do with the least amount of collateral damage to the tissue, it allows the patient to leave that same day or that next day. Imagine, all of us have something. I tell patients all the time, I don't ever want to have spine surgery. If I can ever help it, no way. If I had to, I want to have something that can get me to the end goal without the trauma. And that's what minimally invasive surgery comes through. But then the other thing that I love is fusion. Fusion surgery is great. Fusion surgery to some people sounds really scary. However, done at the right place at the right time, it's an incredible operation. I'm going to quickly go through some cases that will kind of give a description of exactly what these things are. So 24-year-old female banker comes in with severe back pain, 2-year history of lower back pain. And as you see on this level above, L5 and S1, the bone is significantly displaced forward. The only way to address this problem, and her diagnosis is spondylolisthesis, the only way to address this problem is a fusion. No way else to do it. Now, how you get to that fusion is what we do this is we go from the front. My preference, there are different ways to do this. You can go from the front, you can go from the back. My preference is go from the front where you put a cage in there. This is titanium coated. You put bone graft in there, you put screws in there to give an internal splint to make it stable. The pedicle screws are on the right, and as we're putting in the pedicle screws, you're traversing the spinal canal. And so to be able to traverse the spinal canal without any potential issues with the spinal nerves, that's where the navigation comes in, or different techniques that each surgeon uses. And that's what it looks like at the end. So that same patient, which was significantly displaced forward, you can reproduce that with 1-inch incisions on the back. And now again, the front incision I didn't take a picture of. It was about a 2.5 incision from the front where you can stabilize that level. And that's the bottom right picture where it looks like from a post-op standpoint. But clinically, significant improvement of her symptoms. For the sake of clinical outcomes, 51-year-old professional cyclist, same sort of thing, degenerative spondylolisthesis, significant slippage of the bone. You stabilize it, excellent clinical outcome, goes back in and able to do, going back into professional cycling because you're stabilizing that one level because the bone is physically moving. The next patient, 57-year-old firefighter. These are all local patients who come through. 2.5 year history of lower back pain. Had an excellent procedure by an outside surgeon. We had an fusion at L5S1, but has now developed a problem above it at L4, L5. One option is you do a fusion with it. Another option is, which I love, is you do a disc replacement. So rather than stabilizing and make that patient more stiff, you could put a device in there that has a range of motion in all planes that allows you to mobilize immediately day one. You're back to work doing your thing probably six weeks to 3 months as compared to 6 months to 1 year. And you put a disc replacement at that level at L4, L5. And that disc replacement, it's a keel implant, so this literally flexes and extends as it comes through. Next patient, 23-year-old, very common problem, not a common problem, but when it does happen, is a surgical emergency for spine surgery for a patient. 23-year-old bartender, she's had a 3-year history of back pain and leg symptoms, but a 2 to 3 week history prior to me evaluating her with urinary incontinence and numbness in her genitalia. So she had a huge disc herniation at L4, L5, that you see that huge disc herniation, and it's putting pressure on the nerves in her back. Now, the treatment algorithm is immediate surgical intervention where you take off that pressure off the disc, is exactly that jelly-filled donut that is spat out, you're taking that portion out. But as there is a defect in that area, is now this device, which I feel is a complete game changer, that you're able to take that disc out, but put a device in there that prevents another piece of disc coming out. Incredible procedure, and that's what it looks like in real life. So even though on this picture, on the far right picture, even though it looks like it's in the center, I'm on the left side, but I can completely open it up from the center and immediate mobilization and recovery of those symptoms and prevent another piece of disc coming out because there's a 10% chance another piece of disc can come out. 61-year-old quick dentist, see a lot of dentists because ergonomically, for whatever reason, they're bent over. And ergonomically, if you bend over like this or bend over like this, it could cause collateral damage to your neck and back all day long. Significant problems with his neck pain, trapezial pain, 4-level neck problem. Love this operation. Go from the front part of the neck. Historically, what you can do is you can go and where you take out this portion of the disc, you take the pressure off the spinal cord, and you can fuse it. However, I have to do a disc replacement and a fusion because there's a 4-level problem. And so on the slide, on the left side is a disc replacement device. On the right side is a fusion device. And so I did a hybrid. I would love to do a 4-level disc replacement. However, the FDA only allows us to do 2 levels at a time. So I did a 2-level disc replacement above it, below it, and he's able to go back to hopefully his job working as a dentist. And the last quick case, 41-year-old landscaper who I just saw last week on Monday was packing mulch in and felt a pain in his back, couldn't walk. And he goes into the office, 6-month history of his inability to walk. Goes into the office or to the ERs, 3 different ER visits in town, and they thought it was a lower back problem. But it was not a lower back problem. On exam, when you walk, 41-year-old guy, before this injury, he was able to walk perfectly. He was able to walk what we call a broad-based gait. So on exam, he went to Grossmont, we did an evaluation, got an MRI scan which showed a huge disc herniation here, a 41-year-old. And so the treatment algorithm I thought was most appropriate was a disc replacement. So you can have that operation and theoretically go home that same day or next day. His recovery is a little bit prolonged because of the amount of disability that he started off with, but that's what he ended up with. But very, very excited about the future of spine surgery, of robotic surgery, of these different types of minimally invasive techniques that we have at Grossmont. And I think we are destined to be really an incredible spot, not only for the West Coast, but the entire nation to deliver spine care. And I wanted to introduce Dr. Sunil Jaswani, one of my practice partners, an amazing neurosurgeon, an amazing spine surgeon. And without further ado, great.
Hello, everyone. Thanks, Dr. Razadeh. Sorry I'm a little overdressed today. Okay.
Are you on call right now?
Tell me no. I literally just walked out of the OR. Yeah. Okay, I'm going to be talking about a couple topics within the domain of complex spine care. And so we are proud at Sharp Grossmont to be able to offer some of the most complex spine surgeries that are available in the region because of the equipment that we've brought on board, as well as the people that we have that are able to do these kind of surgeries. These are surgeries, which we'll talk about, spine tumor surgery and spinal deformity surgeries, big surgeries, massive blood loss. They usually lose their entire blood volume in one operation. You have to transfuse everything back. Long recoveries, sometimes over a year for a lot of these patients, significant amount of rehab, physical therapy, high risk of neurological deficits. And so there are not a lot of centers that really tackle these kind of problems. And we are proud to be able to serve the community and be a center like this. So one problem I want to talk about that we are doing here is spinal deformity. And as Dr. Razadeh mentioned, a lot of people, most people in this room at some point will have some problem in their spine. Why? Because the spine degenerates. And so when it degenerates somewhat, you can do, surgeries, 1, 2 level disc surgeries or fusions. But as we get older, as our spine continues to degenerate and the discs really start to wear down and the joints really start to wear down in our spine will start to deform. And you can see as people get older, they stop standing up as upright as well, and they're kind of stuck in these kind of positions. And this is a bigger and bigger problem in our community because we are living longer. Back when we were cavemen, we were living to about maybe 40 years of age. And so we outlived our spines before it became really degenerated. But now we're outliving what the natural plan of our spine was intended for. And so our spine degenerates over time. And so what happens? In what we call a kyphotic deformity, our back can start to fall forward. And what happens? So you still want to be able to look upright. So you start really arching your upper back, you start tilting your hips in, you start bending your knees, and that takes a lot of energy. It takes a lot of it uses up a lot of muscle power and turns into a lot of muscle fatigue and eventually pain. And so this is quite a big problem in our aging population. So how do we get a spine to look like this, where it's kind of hunched forward, to look like that, where it's completely back upright? Well, number one, it takes a lot of math, right? We know what the curvature angles are in different segments of our spine. We know how it should be aligned relative to our pelvis. We have all different mathematical parameters and angles and calculations that we look at to try to get the spine to get what it's supposed to look like so that the head is pointing straight up and is using the least amount of muscular energy around the spine so that the pain is minimized. The other problem we're seeing is that back in the 90s and 2000s, we were just putting screws and rods in everybody without really knowing what we're doing, just fusing everything. But we were fusing them in positions like this and making them stuck like this, what we call iatrogenic deformity. And now those patients, as they're hitting their 70s and 80s, or sometimes even 60s, and they had these surgeries 20 years prior, 30 years prior, we're seeing more and more of these deformity problems as a result. So when we start planning these deformity surgeries, we have to do a lot of mathematical computation. How much curvature do we need to bring back in this part of the spine so it matches the curvature of the pelvis? How much curvature do you have to bring back in the upper part of the spine so that the head is directly above the pelvis and they're looking up straight? Once we do all that mathematical planning, then we take the patient to surgery. We're literally filleting open the entire spine from the upper back all the way down to the tailbone. And then we're putting on screws and rods at all these levels, segment by segment, all the way down. And these screws have to be in there perfectly, so they don't hit the spinal cord, as Dr. Razadeh was saying. They don't hit the nerves. They're directly in the bone where we want it to be. And if we're putting in 30, 40 screws in the spine to correct someone's deformity, you can see the chance of one of them being off and causing some sort of catastrophic problem could be high. Once we put the screws and rods in, then we break the spine. We literally have to break the spine to get the spine back into a normal curvature at sometimes multiple levels, or sometimes at 1 or 2 levels where we really, really break the spine. That's where it gets very bloody. You can lose 2-3 liters just from breaking the spine and drilling wedges into the spinal, into the vertebrae, because there's so much blood flow to those bones within the spine. Then we have to put long rods to hold everything together and then close the patient up. So you can see this is a big ordeal. Sometimes these surgeries take 12 hours, sometimes they take 2-3 days. We end up transfusing tons of blood. They're in the ICU afterwards, they're in recovery, and then they're getting therapy and rehab efforts for upwards of a year before they're somewhat functional again. And you can see that things have to go perfectly every step of the way. So this is now why, as of last year, we brought in new technology. As Dr. Razadeh mentioned, our spinal navigation and robotic systems and intraoperative image acquisition systems that can make this a lot more accurate and allows us to do these surgeries in a more minimally invasive fashion, so we can minimize blood loss, minimize length of stay, maximize outcomes, minimize complications, and have basically our spinal corrections of these deformities be as accurate and as precise as possible. And so with these systems, we can acquire images of people's spine, 3-dimensional images in the operating room. We can send those images to a navigation system in the operating room. Then we can use that navigation system, which is like a GPS system for the spine, to put the screws in at every single level, exactly precisely within 1-2 millimeter accuracy. And then we can use that same navigation to do our cuts in the spine, to break the spine, so that we can do exact wedges down to 1 or 2 degrees. So when we close those wedges, it is exactly what we planned in the preoperative stages. Then we can then put in custom implants and rods to hold the spine in place exactly how we had planned it before the surgery. And I'll come back to this slide a little bit. So this is our robot system. You can see with the robot system, it integrates with the navigation system. And so the robot arm automatically guides itself right into the right spot. And basically, anyone can come in and just drill where the robot is telling you to drill and put the screw in through the shaft. First-year medical students do this now because the robot can handle this in such a semi-autonomous autonomous fashion. You can see here.
Not at Grossmont.
Not at Grossmont. That's at UCSD.
At Scripps, they do that.
At Scripps. Was I not allowed to say that? I came from UCSD, so I can say that. So you can see here, with the navigation system, we can plan exactly where we want the screws to go, and the robot can deliver these screws exactly in the bone channels without hitting the spinal cord, which is here, or the nerves coming out the foramen out here, with 1 millimeter accuracy. What we've also acquired is, with the acquisition of this equipment and this technology, we've also acquired a collaboration with engineers that can help us do these mathematical calculations and tell us exactly where to make the cuts in the spine, so that when we correct the spine, we have it in perfect anatomical alignment. And now there's a big push to incorporate machine learning and artificial intelligence in an area called predictive analytics. Well, we want everyone's spine, to fit this mathematical formula where the head is directly above the pelvis and we get all the curves correct down to 1 or 2 degrees. But does that work for everyone, right? Do you really want to do that? Do a big correction in an 80-year-old to get them from here all the way back, or are they better off just being a little bit off but save them, a big surgery where you lose a lot of blood, right? So you looking at large databases of patients in the thousands and see how they do and what kind of characteristics they have with patients that don't have a lot of muscle mass, or patients that have weak bone density, or patients that are older. What's the best outcome? How much do we correct them? It's not, cookie cutter, one size fit all for everyone. And so using AI and machine learning, we can predict, well, maybe these patients we don't want to correct too much. We want to correct the deformity a little bit less. These patients could tolerate a little bit more, because these machines have learned what patients do well with what type of surgery. And now we're incorporating that as well with our surgical planning, navigation, robotic systems. This is the image system that we've acquired in the operating room. This is called the O-arm. So this is what we bring into the room. We acquire the image and we send that to the navigation system, which then works with a robotic system, so we can deliver these implants in a very precise fashion. This is some of the mathematical calculations that we do with the engineers, which is state of the art. We're calculating a lot of these angles and curves, and then we can predict, if we drill a wedge in this vertebrae and we close that wedge down, what will the spine look like? So it takes a lot of collaboration between the surgeons and the engineers, and we're proud to be a center that has that collaboration. Spinal tumor surgery. This is the other area I want to talk about. So spinal tumors, especially those tumors that originate from other parts of the body and then spread to the spine. This is where we've really made significant gains. We're seeing more and more of these patients because, again, patients are living longer, so they have more opportunity to get cancer. About 20% of cancer patients will eventually get tumors to their spine. Cancer patients are living longer in general because we've shifted away more from chemotherapy to more molecular targeted agents. Our radiation therapies have gotten better, and so we're seeing this problem more and more. When we do spine tumor surgery, our goal is to get the tumor away from the spinal cord so that we can give the remainder of the tumor radiation. If we give radiation without doing surgery, then the radiation comes too close to the spinal cord and can injure the spinal cord. So the name of the game is to get the tumor farther away from the spinal cord so we can give radiation safely. But when we do that, we usually have to drill off a lot of bone, and we have to put screws and rods to hold everything together. If we put screws and rods, and we usually use titanium screws and titanium rods, then what happens when we try to plan radiation, we can't see anything because the screws and rods just create a big blur on the MRIs after surgery. And so it's hard to plan targeted radiation to that area because you can't really see where the tumor is because all the metal artifact from the screws and rods. The other thing is that when you give radiation, when they have titanium screws and rods like this, it scatters the radiation, makes the radiation less accurate. It can end up in spaces outside the tumor. So we have now brought in carbon fiber screws and instrumentation. And so with carbon fiber instrumentation, you can see this is a carbon fiber implant. If you compare this to what we did in the past, now with carbon fiber screws and rods, you can barely see them on an MRI, and you can see the spinal cord and the space around the spinal cord much more clearly, which allows our radiation oncologist to plan radiation in a focused manner to the remainder of the tumor in a much more precise fashion. And so this is basically the radiation planning. And so we can now deliver radiation to the tumor while avoiding the spinal cord and do it accurately because the metal from the titanium isn't creating all this streak artifact, and we can exactly see where we're delivering radiation. And so this has allowed us in the domain of spine tumor surgery to really advance our care, because now with the bringing in spinal robotics and navigation, we can put in all the screws and rods minimally invasively. We can then, in a minimally invasive approach, drill out just enough tumor. We don't have to take out all the tumor anymore. Just drill out enough tumor to get it away from the spinal cord and deliver high-dose focused three-dimensional radiation via stereotactic radiosurgery to the left over of the tumor, and get the same type of tumor control as we would have gotten in the past when we had to take out all the tumor and cause massive blood loss and huge recovery times. And we can now do these through small incisions, minimally invasively, with robotics and navigation, get the patient home in a day or two and start their chemotherapy and radiation very soon thereafter, which is what they ultimately need. Thank you.
Yes.
seeing this. So I'm going to talk about what is a neuro-ophthalmologist. So you guys all know what a neurosurgeon is. You've probably heard of stroke and neurologists. Neuro-ophthalmology is a little different. So I always get asked by patients and their families, what exactly do you do and why are we seeing you? So I'm part of this team because I take care of patients who have brain problems that result in visual symptoms. The most common thing, decreased vision, visual field defect, that sort of thing. But sometimes it's a much more vague thing that's, intermittent double vision, or like some people describe it as visual snow. So I'm here to help these guys diagnose things earlier. And so my goal of today is to just introduce you to some of the things we brought forward. So specifically, how does a neuro-ophthalmologist help neurosurgeons diagnose things? I work with stroke, I work with movement, but today we're going to talk about the tumors. So if you look at the eyeballs, so this is the eye area, you can see it's very close to the brain, and that this blob here is probably not good. And so this blob here, this blob there. So tumors can be either behind the eyeball in an area called the orbit, or it can be in the brain, most commonly in an area called the paracellular area, or where the pituitary is. And what's really hard is that general ophthalmologists and glaucoma specialists don't get to see the brain. And so there are now tools that help me know it's not glaucoma. So when I'm doing different neuro-op things, there's definitely a variety of misdiagnoses that I run into that to me seem really common, but for others it's hard to see. But this is the most common one that I see that we got to really act on. So glaucoma, super common. Normal pressure glaucoma, glaucoma with high pressures, glaucoma of different kinds. Space-occupying lesions, less common, but pretty common. I heard earlier you're talking it's raining cranies. Month of December, month of November, I don't know why, but there's always so many tumors, orbital tumors, intracranial tumors. And so I want to just point out, and I had one of our doctors ask me, I don't understand why you think this OCT thing is so important. So let me show you. So glaucoma and a brain tumor actually cause pretty similar things. So they're progressive. So people go to their glaucoma specialist or general ophthalmologist or optometrist, and they get visual fields. They get these other tests called OCTs that I'll show you. And you're followed over time, and your pressures are followed over time. But the problem is, when you have a brain tumor or you have true glaucoma, you share all these things. So it's progressive, it's painless, the intraocular pressure can be normal or can be high. There's different visual field changes that both can share. And then there's this nerve fiber layer loss on the OCT that I'm going to show you. And then what's also important is that optic nerve cupping, which is in the back of your eye, you have an optic nerve, and it's shaped as a circle. And most people have a little circle inside the circle called the cup. And it's usually like a third of the total size. Glaucoma is characterized as that cup getting bigger and bigger, but compressive optic neuropathy does the exact same thing. So it can be very, very confusing. So here I'm just showing you something super cool. These are VF goggles that have been modified to check vision, contrast sensitivity, visual fields, motility, and now they're even checking pupils. So just sitting anywhere, you can sit in the intensive care unit, in a hospital bed, in a comfortable chair. You don't have to lean in and be in an uncomfortable position for 20 or 30 minutes. These capture a lot of information in only 2 to 3 minutes. So super cool, and we're using these here at Grossmont. Most important, though, is this micron assessment. So these guys are talking, gross resections and blood loss. I'm talking teeny tiny changes that detect the architecture of the back of your eye. That's only like less than a half inch in thickness. And so these tools are able to use really advanced assessment and figure out which layer of your back of your eye is missing or damaged. And so it's really, really, really helpful. And these patterns of either thinning or thickening, to me, make sense and clue me to that this patient has a pituitary tumor, or this patient has a tumor that's farther back, or this patient has a tumor that's behind the eyeball. So very sophisticated, very cool testing. So again, here's the eyeball, and I'm not very far from the brain. So even a small tumor, and I'll show you one case that I shared with Dr. Natarajan, even a small tumor in the wrong spot can do a lot of damage. And then especially these tumors that are in the area right behind the eyeball, called the paracellular area where the pituitary sits, can do bad stuff. So when I talk to my patients, I'm going to ask them different things, and I've got Courtney in the audience, and she's my nurse practitioner extraordinaire. And so we talk to patients and look for clues in their symptoms that suggest something else might be going on before we go on to do these special testing. So early morning headache is not normal. If you ever have somebody you know who wakes up with a headache, it's a brain tumor or brain process until proven otherwise. Early morning headache, bad. But I'm also going to talk about dizziness, imbalance, change in the shape of their face, change in the shape of their eye or the appearance of the eye. And I often ask, does your eye or your eyes feel different? And that can be super helpful and have a clue that the patient's having something more. So what are the associated signs? So pupils that don't work. So an afferent pupillary defect means that the brain's not getting the same amount of light to the two different pupils. Color desaturation. If you look at the color red and it looks orange or brown, you've got an optic nerve problem and it's probably not glaucoma. A visual field that's much, much worse than this OCT, that laser interferometer, that's a bad thing. And if your eye bulges or looks different, super, super important. And then finally, if you have thickness out over here where you're supposed to go in, that can be a meningioma or another process. So this is my favorite thing in the whole world. And Scott bought me two. No, the foundation did. So OCT, we are the only hospital that has the OCT and is going to deploy it in both the emergency room and it's in the Neuroscience Center for the purpose of identifying brain tumors. It is a tool used by my retinal colleagues. It is a tool used by ophthalmologists and optometrists, but this is just so super crucial. So this is not when I want to meet Mr. Jones, right? Dense defect, red is bad. This is when I want to meet Mr. Jones. When there's no visual field defect, there's normal vision, but the patient's having progressive visual symptoms, and now all I have is some thinning on this very sophisticated machine. This is when I want to send them over to my neurosurgery colleagues and say, okay, here's the scan and here's the tumor. Because this is such an important clue to me that this is not glaucoma. This is an intracranial problem, most likely a brain tumor. So the roll, this is what it looks like. It's pretty small. The patient just puts their chin right up here and just looks at a green light, takes just a moment to capture the image, but captures an image of the micron dissection of the whole back of your retina and optic nerve in such a sophisticated way. It looks for all the world like a pathologic dissection. So very cool, very, very, very advanced. So let's just do two cases. These happen to both go to Dr. Natarajan, but 71-year-old gentleman, no family history of glaucoma, but he was followed for what was called normal tension glaucoma, and he had progressive changes on his visual fields and progressive changes that he felt like he just wasn't seeing as clear. The key was that there's a special part of the OCT test that clues me that this is not glaucoma, because the pattern of it pointed to the fact the patient had something else going on. So we imaged him, and he ended up having a relatively small mass right in this area, but when it's in the wrong spot, it can cause a lot of problems. So he went on to have surgical intervention and is doing extremely well. 47-year-old African-American woman who presented with light perception, so basically can't see at all in one eye, and now she starts to lose vision in the other eye. She had seen multiple different practitioners, and she had a very low pressure, but was on glaucoma drops again. And the eye that couldn't see well had pallor, as did the other one, the beginnings of it. And again, there was this pattern on the OCT, that special test, that clued me in that there was something much more difficult going on than just glaucoma. And this area right here, this is all bad stuff. So that's the area of the pituitary, and that's a big pituitary tumor. And again, she was referred, had the vision in her better eye saved, when patients go to this level of blindness, and it's been like that for a long time, there's no getting it back. But if you lose vision in one eye, it's one thing. If you lose vision in both eyes, you can't drive, you can't function. So again, a real win. And there you go, Dr. Natarajan.
Thank you. Thank you, Kim. I'm Dr. Natarajan. I'm a neurosurgeon, but I also have special training in treating brain diseases with catheters, like Dr. Weeds, and I also do radiation treatments to the brain. And the reason to have all these three integrated, it took me a lot of years to train that way, but is that it kind of puts the patient at the center. And I have no bias of doing neurosurgery versus catheter-based treatment versus radiation treatment, and it's what the patient wants. And sometimes I cut corners, meaning which, if something is difficult by open surgery, it's easier by catheters, we do that way. If something is lesser on the patient by doing it with catheters, we do it that way. If radiation is better, or a combination of. So, it kind of makes us choose what is the best combination and kind of creates a science around it of, okay, if someone has the capability to do all three, then what would you choose and how would you treat the patient? The thing is, these patients go through 3 different doctors, and these 3 doctors are not talking to each other. But then they can come to one physician, and that one physician can give them, what they need to know about all 3 different modalities. So that's kind of reason why I spent a lot of years training to do what I do right now. I'm going to focus on the technology we have at the new Neuroscience Hospital. So this technology I'm going to talk about is used to treat primary brain tumors and metastatic brain tumors. Primary brain tumors are tumors that arise from the brain, in the substance of the brain, and metastatic brain tumors are tumors that come from, say, a lung cancer patient has a tumor in the brain. So how do we ensure that we are accurate in resecting this brain tumor? How do we preserve function in these patients? And how do we make them recover faster? So the same principle, accuracy, preserving function, minimal invasiveness, and quick road to recovery. And that's really what the technology does. And my business development team here, Daniel Kindron and Nusha, have been painfully listening to me. We need more, and they bought most of it. And thank you for doing that. And I'm going to start with optical and frameless navigation. We all drive cars. We use navigation now. We have autopilot, right? This is like navigation in the brain. It tells us, okay, I can plan that this is the trajectory I'm going to take to get to a part of the brain. What is tractography? You can see here the brain is full of connective fibers. And these connective fibers have function all over. So if disrupt a connective fiber, we all thought that a part of the brain has function, but that's not true. A network of fibers, Dr. Chalkula is going to talk about that, I'm sure, has function. So if we disrupt a network of function, then we're going to disrupt function. So we have an ability with the technology that has been brought at Sharp Grossmont Hospital to look at these connections in the brain and to see where they are in 3 dimensions in the brain in relation to the tumors that we have in the brain. And what that does is I can avoid these connections and get to the brain by doing a 3-dimensional surgical planning. The third thing is ultrasound. So we get a CT scan, we get an MRI, and we go into doing the operation. As I do the operation, the brain starts moving. The tumors come out, and the brain starts moving. So whatever I had a reference for navigation, which is the CT and MRI, now has changed. So I don't have a real time of what is happening in the brain. So we have ultrasound where we can use the ultrasound, and now I know exactly what is happening minute to minute in the brain. And now I can correct for the changes or shifts in the brain that happen, and that can integrate into navigation to improve accuracy. The fourth thing is, I'm sure a lot of us have seen YouTube videos of brain surgeons doing surgery, someone singing, someone playing a guitar, someone doing a task. So basically what it is we have a brain tumor next to an area of the brain that is functional. What we do is we put the patient to sleep, we open the head, and then we wake the patient up. and there's someone asking the patient to do the same task that they are doing, so that as we do the surgery, we know we are close to the functional area and we can stop. So we can do that at the New Grossmont Neuroscience Institute. Ghrelin is a medication that we give, that we inject through IV. The reason to do that is sometimes the brain tumor and the regular brain is very difficult to differentiate when we look under the microscope. So when we give this medication Ghrelin, the brain tumor is very distinctly seen as pink fluorescence. And we have special microscopes, and we have introduced Ghrelin therapy with our pharmacies help. And we have the Ghrelin program where we can resect these tumors safely, and we can differentiate very well what is brain tumor and what is normal brain. I'm going to show AutoGuide, which is a robotic cranial access system, just like the spine robotic. What it helps us to position in a trajectory of where we need to go. And the robot positions us in the trajectory so that we can access a pre-planned trajectory into the brain so that we don't disrupt any of these fibers and we take corridors to the brain. And when we do that, we need small ports. So basically these ports are a diameter of a centimeter, centimeter and a half. They are 5 centimeters deep. And you put them, the robot puts them in that trajectory in the depths of the brain. And then with high microscopic magnification, with a Kinevo microscope, you can actually magnify, and through that 1.5 centimeter hole, we can take tumors that are 4 centimeters large, 5 centimeters large. And that creates small incisions, smaller craniotomies, quicker recovery on these patients, preserving function. So we have all of this technology in our Neuroscience Institute so that we can do these patients' surgeries with precision, with safety, preserving function with quick recovery in a minimally invasive fashion. This is another thing which is my passion. I did a year of fellowship training to do this. Dr. Cochran kind of talked to you about this. So if you think about it, the skull base is really the connection between the brain and what is below the brain. And if you think about it, in the front, you have the eyeballs. In the center, you have the nose and the throat, roof of the nose and the roof of the throat. Here you have the ear and the apparatus for the ear, and here you have the top of the spine. So if you have disease that is going from the eyeball into the head, or from the nose into the head, or from the ear into the head, or from the top of the spine into the head, then you'd require special expertise to go through these areas to do this. Why is it important? Because everything from the brain goes through these small orifices in the skull base, including vessels and nerves, to connect to every part of the body. And so if you damage a small nerve or a vessel in this part of the skull base, then these patients are going to have neurological dysfunction. So how do we operate with all of this? Then you need someone who has an expertise in doing open surgery, skull-based surgery, catheter-based treatment, and radiation treatment together so that we can choose the correct treatment to do this. And we can do it through the nose. We can put in an endoscope through the nose and go to the behind of the nose and then drill this part of the bone to come into the head to do it. We can go through the orbit and then go through the orbit with an endoscope and then come to the top of it. We can drill this part of the bone, preserving hearing, and come close here so that we can operate in the center of the brain. We can also operate right here where the connection between the brain and the spinal cord is so that we can take these tumors out. And this requires management of the vessels, and someone with an expertise in managing the vessels with open and endovascular helps preserving these vessels and function and blood flow to the brain as we operate. And some of these surgeries are very long. The longest I have done is 60 hours on a brain tumor over 3 days, right? And commonly they are 12 to 16 hours long. And I'll tell you why that is important and what we have at Sharp Grossmont to do this. So there's multiple disciplines of expertise, right? You do open operations, you do catheter-based treatment. You can see that this is a very big tumor. It goes almost from the front of the head to the back of the head. The carotid artery which supplies both sides of the brain is right there. This part of the eye is right here. The ear, apparatus, and the brain stem which connects the brain to the spinal cord is all in the tumor. This took me 22 hours to resect. And this is the scan after surgery. There is no tumor left, right? And so this requires expertise of doing open surgery, catheter-based treatment, radiation, an ability to do understand neurocritical care so that we can manage these patients in the neurointensive care unit, and then sometimes understanding biology of these tumors so that we know which tumors are aggressive, which are not aggressive, so that we can treat them well. And as I said, a lot of people are involved. I can connect these people and I can do what my part is. Like there's medical oncology, there is radiation oncology, there is ENT specialists, which is ear, nose, and throat specialists. There is head and neck specialists. There's plastic surgeons, because when we do a tumor, when we take the tumor off, if we cannot close, then we need plastic surgeons to have a free flap to close the patient. We have ophthalmologists who focus on plastics, nerves, and orbit. We need neuropathology because we need to do genetic analysis of these tumors, which guides into what kind of chemotherapy or radiation we needed. This part, as I said, is the most important. I'm glad our new hospital has a big emphasis on rehabilitation, because when you do a 22-hour surgery, these patients wake up with neurological dysfunction, okay? And they need physical therapy, they need occupational therapy, they need speech therapy, they need rehabilitation because the brain is annoyed that you've been around them for 22 hours. And we need to help these patients recover after such a major surgery. And I can kind of bridge 2 or 3 of these disciplines, but still these patients need a lot more people, doctors, to see. So we create oncology navigators so that these patients can know where to go, how to have their care, so that we can comprehensively get their care. And we collaborate with clinical trials so that if there's a patient who needs a new therapy, then we can bring that kind of therapy into these patients. I'm going to show you some snippets here. This is if you see a tumor which is deep in the brain, right? And these green tracks and the pink tracks, these are the tracks or the connections in between parts of the brain. And you can see here on this computer, we do a planning of how I'm going to get to this tumor without affecting any of these tracks. And you can see that this is the tumor, and this is the connection, and we plan a trajectory coming like that to get to that part of the tumor. And once we do that, what we do is we use the robot. And this is the robot. You can see here, this is our first case that we did with the robot at Grossmont. It kind of plans that trajectory and it goes in parts by itself. We make a small 2-centimeter incision, and then after the robot is positioned, we take a drill and we go through a 2-millimeter hole in the skull, and then automatically that robot parks this thing all the way into where we need to go. Okay, and I'm working with companies now to kind of develop technologies where we can put that port we talked about with the robot in the head, just like this, so that then we can do surgery, actual surgery, through those ports in the brain. And you can see that the robot is automatically getting us where we need to go. And this is millimeter by millimeter precise. And you can see the incision in the skin and the skull through which we can go to the depths of the brain with precision. Some cases here. This is a 24-year-old gentleman who has been having seizures, increasing seizures over 1.5 years. When he came to our hospital, he was having 3 seizures a day. He was not able to speak, and he was not able to move the right side of the body. You can see there is a big tumor here on the left side. This part of the brain controls movements of the right side of the body, and this part of the brain controls his speech. And this tumor is right next to it. This guy came to us on a Thursday. I had 2 cases due on Friday, but the guy was not able to speak. The guy is not moving his right side. So we took him for surgery, I think around 4 p.m. on Friday night. And it was a 5-hour operation. We had very good monitoring to monitor all these nerves and function. And you can see that is the postoperative scan. There is no tumor left, right? The surgery was for 6 hours. He woke up in 1.5 hours after we closed the skin, completely neurologically intact, and was able to talk, and was able to move the right side of his body. And the reason is the precision, the reason is high microscopic magnification, and the reason is meticulous neuromonitoring during surgery so that you don't violate functional tissue. And Sunday morning, he went home. And I've seen him, this surgery is almost 4 months ago. I've seen him since, and he's doing well, no seizures. This is another lady. She's a UPS worker. She's been having progressive headaches. And when she came, she was obtunded. You can see that this is the front. This is the nose. This is a big tumor right smack in the center of the head. Same thing you can see right here. This is the top of the head, bottom. This is the roof of the nose. Big tumor. These are the fluid spaces of the brain, right smack in the center of the head, and the entire brain is around it. So how do you get to this, right? So because there's so much of functional tissue, your entire brain is around this, right? So that's why knowing anatomy, microscopic corridors, and so what we did is there is a separation between the brain, the right side and the left side of the brain, right here. We came down here. There is a tissue called as a corpus callosum connecting here. So we knew the front of the corpus callosum, which is right here, is not functional. So we can make a centimeter incision in the corpus callosum. So we came down through this fluid space. And then there is this tiny hole here, which measures around 3 to 4 millimeters in size. And surrounding this is the memory of the patient. Like we have a structure called as phonics. So if I am off by a millimeter this way, that way, the patient is not going to have any memory. And we have a 3 millimeter corridor at around 8 centimeters depth in the brain to take a 4 centimeter tumor out, right? And we did this. This was a 6-hour operation. And this is the postoperative scan here and here. You can see that there is no tumor left. You can see our corridor. We came here. We made an incision here. We went through this tiny hole, and all of this tumor is out, right? She's back working at UPS. And it's been around 6 months since we did this surgery. This is another gentleman who has this 8 centimeters tumor. When he came in, he already had some visual loss. I don't think we can get back the vision because that part of the tumor is in the part that the vision is. But then we didn't give him any more deficits, and you can see that we almost resected the tumor right like how the tumor was drawn, like with precision, right? So that we don't affect any more brain tissue. And in these cases, if you resect it completely, and if you don't give them more neurological deficits, they have the longest survival. And he lived as long as he could after this resection. This is the patient that Dr. Cochran referred to me. This is a 47-year-old lady, didn't have vision in one eye, the other eye losing vision, right? Couldn't read, couldn't see her children. And you can see that right here is the nerve for her vision. And you can see that the tumor is pushing on it, it's torquing it to that side, right? So what we did, we came underneath the brain, in between the two vessels that supply the her brain, and then we were able to take the tumor out. Within 3 days, she was able to read. Within a week, she was able to see her children, and now she's in college, back in college, and she's working and she's doing well. And we got a complete resection on this. It's a little video, it may be a little queasy, but I just want to show this. This is what we see under the microscope. This is magnified probably 10, 15 times. This is the nerve for the right side of the brain, left side of the brain. These nerves are 4 millimeters in size. And there's a tumor that is pushing this up. And I'm going to let this video play to see. So you can see here, that's the nerve for the right side going into the eyeball. And I'm dissecting it. As I said, this nerve is 4 millimeters in size. And we are precisely going, and that is the nerve from the other side. They join together. And the brain is on this side. And you can see that I'm dividing all the small little fibers and lifting the brain. That is the main artery that supplies the right side of the brain. And we are we're not going in the brain. We're going in between the crevices of the brain so that we preserve the function of all these tissues. We preserve the blood. And that is the tumor right here. You can see that it's pushing that nerve up. And this is the optic nerve. This is the orbit. So I'm going from the brain into the orbit to decompress the nerve. And we are trying to take the tumor out. So this is, as I said, it's around 20 times magnification, and you can see the precision. And this is the Kinevo microscope. And we have this technology here to do this operation. Another patient, this is a high school student, big tumor, suddenly lost vision. Why? Because there's hemorrhage in this tumor, okay? And this thing we see here, right here, that is the nerve that is supplying the vision, and you can see that's stenting up. So what did we do? We went through the nose, we went through the back of the nose, we drilled out the bone here, and we got a complete resection of the tumor. You can see there is no tumor left, and that is the nerve for the vision, and you can see now it's down and floating, right? And he's doing well. He's a year out after surgery. Another lesion, it's not a tumor, it's a vascular malformation. Here is functional tissue, so if you go through this person will lose their speech. Okay, what did we do? We drilled off the bone here, and you can see here we came all the way low. We made a cut right in the brain where there is no functional tissue and took all of the thing off. So using skull base, using microscopic surgery kind of helps us to do all of these things. Another big tumor, this is the one I showed initially, which we got a complete resection. And this is the last case. This is a combined case where you can see there's a big tumor from the nose going into the head. And what did we do? We went from here through the nose to take all of this tumor out. But after we take this tumor out, there's a big hole here. And we all know there is pathogens in our nose, whereas the inside the head is a place where there is no organisms. So what do we need to do? So we had to do a craniotomy where we had to open the head and we had to create a flap to create a separation. You can see all this tumor is out, and then we separate the nose from the brain so that there is no microorganisms that go from here to there. So again, this requires multiple people, multiple different specialties, multiple different techniques to be able to do this, and then good rehabilitation and technology to be able to get the best outcome for these patients. And I think we have all of this here at the Sharp Grossmont Hospital, and I think this is just the beginning, and I believe this is going to become one of the best destination places for neuroscience in the future. Thank you. I'm going to introduce Dr. Chavakula, who does functional neurosurgery. I think that is the new frontier in neurosurgery. Every development in neurosurgery is functional neurosurgery, and he's doing some exciting work here at the Sharp Grossmont Hospital.
Thank you, Sabarish, for that kind introduction. Thank you, everyone, for coming and being here. I think we're all very excited about the opening of our brand new center. I wanted to talk specifically about movement disorders in neurology and neurosurgery. And people ask me, what are movement disorders? They are disorders that concern the parts of the brain that are responsible for controlling movement. If you were to think about the car, this would be the accelerator or the brake, starting or stopping movement, and the steering wheel. I tell people, imagine seeing a 16-year-old learn to drive. They go to the right, then the left, and back to the right, and back to the left. That's what a tremor is. So really, we're talking about their strength, their sensation, but people just can't seem to move the way they want to do. And these are oftentimes lifelong debilitating conditions. So these are patients that I tell them, you're my patient for life. And so the goal is we need to give them a home where anytime something is going wrong, they know where to come in. And that really is the point of a comprehensive movement disorder program. I'm telling my current patients, right now it's a rendering, soon it will be a real building, but I say that's where you're going to be. If you need physical therapy, if you need occupational therapy, if you need speech therapy, that's the ground floor. If you need to see one of us, that's the second floor. If ever you need to be in the hospital, up in the third floor. And I think that sense of there is a place for me to go is really what we're the most excited about. So that's really what the focus of cross-specialty care under all one roof. And for a lot of these patients, as I mentioned, these are progressive conditions. They have good years, they might have bad years, sometimes things are going well, sometimes they're not. And every once in a while, they just need somewhere to come where they can be reevaluated. So we provide a place now for all of our patients where they can have neuropsychological exams, physical therapy evaluation, occupational therapy evaluations. People can have difficulties with speech and swallowing, and sometimes they're embarrassed or don't want to talk about it, but those are things that we can monitor too. And one of the most exciting things are for my movement disorder patients, that they can do all of those in the same morning or afternoon session. They say it's a difficult 3 hours, but they're like, there's nothing like just getting it all done instead of having to organize these appointments, having to organize drivers, having to organize going and coming over a month or 2 months or even 3 months at a time. Now, some of the treatment options that we're offering really were not even considered to be something that you could do outside in the community hospital. They were at major centers of excellence, at only academic centers. When I tell even my colleagues that I'm doing deep brain stimulation at Grossmont Hospital, they stay in the hospital one day, and that's it. They're actually pretty shocked. So people are in, they're out, they're back to their normal lives, and they're doing quite well. And the focus of the talk today is about memory-guided focused ultrasound, of which we're a technology that is really only offered in the San Diego area at Sharp Grossmont Hospital, really thanks to the leadership of the hospital and the system, as well as the Grossmont Hospital Foundation, which really made a huge impact and made this a real possibility. So really, we're going to be talking about tremors. Tremors, most people say, I can live with them, especially when they first start. Maybe it's just a jiggle of the wrist. But then sometimes they can get quite progressive. People first say, I just kind of sit on my hand, I make sure no one's seeing it. Soon, if it gets to a point where it's shaking all the time, they say, I stop going out to eat, I stop going out to social events because I'm concerned that everyone is looking at me. And oftentimes what we know with tremors is that the more anxious someone gets, the worse the tremors get. So they say, I go out, I feel anxious, and my tremors get worse. I find really home is the safest place for me, and that's why I really don't want to go out. And so the goal is, how can we let these people recapture their life? How can we let them go back out into the community, do what it is that they want to do? I've had patients who say, all I really want to do is put on makeup. All I want to do is eat at a restaurant without spilling on myself. A patient that I saw who came back for his one-year follow-up, he said, the best thing I did this year was, I said, what? He said, I got to give the toast at Thanksgiving. So things like that, which, we don't even think about, but I was like, oh, I guess that was the most fun thing. He's like, I didn't spill on anyone. He's like, all my family were so proud of me. So I think those are the little moments and pieces that we want to give back to people. And so MR-guided focused ultrasound, it didn't even exist when I started in my training or my residency. It's basically an incisionless surgery. So as much as Dr. Rosday and Dr. Viets do minimally invasive surgery, I don't like the incisions at all. So this is a surgery where there's no cut, no hole in the brain. We are using ultrasound-guided energy. I tell patients it's an ultrasound knife. And that's really what makes a small lesion in a part of the brain called the thalamus, and that it's like a cardiac ablation. It stops these abnormal brain circuits that are causing these tremors to occur. And the results are instantaneous. I tell patients it's a 90-minute procedure. The best tremor control you're going to be having is at the end of that 90 minutes. And we finish the surgery. They come out. There's no anesthesia, so they're awake the whole time. They're participating with me. We'll actually show one of our procedures at the end. And they're like, I have not held a glass of water in 10 years. So it is really shocking for patients and for their family. I'll see their families crying in front of me right there. And in the beginning, it was kind of overwhelming. Now I'm like, okay, it's another one, another one. But for them, I think it is really magical to suddenly be able to do some of these things that they haven't been able to do in a while. As I mentioned, this is a picture of what some of their writing will look like. They have a hard time. This is what we call spiral task. Basically, I say start with the pen in the center, stay within the lines, and just draw a spiral for me. That's at the beginning of the treatment. And then that is right at the end, at that 90 minutes after at the end of the treatment. In terms of the results, it's so new, I don't have 10-year data. I tell my patients, the 5-year data for this procedure just came out. And at 5 years, what we found is 73% of people have had a marked reduction in their tremors that they're quite pleased with. So people are quite excited. They're telling their friends, they're telling their families. The one caveat to this procedure I tell everyone is we can only do one side at a time. So we could do the right side or the left side, and in a year you can come back and get the second side done. And even that advancement was only even allowed within the past year. So this is really a rapidly evolving technology. Next slide. We've only had 6 months of data for the second side. So at the second side, we can say patients have an 80% improvement in their tremor and their hand function in both sides at 6 months. And so this will just slowly keep adding. I tell every one of my patients, you're going to come back and tell me how this is going. We are advancing the field as we move along. And part of the excitement about this technology is, we're going to be at the forefront of developing. Some of you have seen, this is being studied for the treatment of Alzheimer's, treatment of dementia, treatment of epilepsy. There's really a whole world that's open. And because we are at the forefront, you are going to see more and more of what we can do with this technology as the years go on by. Just want to let you know, we did our first case in November 16th of 2023. We did 45 cases in 2024. We're hitting number 50 at the beginning of February, and we've got a lot more scheduled for the year to come. And really, I think we're excited. We're the only ones doing it here. And then we've got a video, so we will go ahead and show the video.
This tremor started approximately 15 years ago. Unfortunately, over the years, it's gotten worse. Now, I can hardly function doing some things.
Her tremor is really when she's eating and drinking and especially holding heavier objects. This procedure is based on how can we target ultrasound energy to a very focal point and cause an increase in temperature in the brain to the point where we cause a lesion. Maybe about a pea-sized is kind of what I tell most of my patients. As we mentioned, there's no knife, no incision. We're really using focused ultrasound waves to go through. And we make a lesion in the brain to disrupt the tremor-causing circuit.
The big day is tomorrow, and I'm just about to leave to go to my hair salon and have my head shaved. His hair, it'll grow, or maybe I'll just love it and embrace it.
We are the only ones in San Diego providing focused ultrasound. Having such a short procedure time and being able to see the really quick results is amazing.
Morning of procedure, you come in, we shave the head basically, and this is the cleanest shave you'll ever have, and that's because hair blocks the sound energy from getting through. We start with the placement of the frame or the head holder. That looks good, so we're just kind of lining it up. Okay. We walk you over to the MRI, and then what we do is we actually put the helmet over your head, and we fill all of this with water. So it's cold water, and the cold water is actually what lets the ultrasound energy go from the actual helmet and the transducer through the scalp and bone and to the brain itself. We are going to go ahead and identify our target. Since we're treating her right hand, we actually have to make a lesion in the left thalamus, or the left side of the brain. So we'll start with about 2,500 joules, which we're going to deliver to her. And that sound is the energy being delivered as we speak. The screen line shows that we are delivering all the energy that we want to deliver at the moment. This green dot was my target. And as I go up in temperature, I can tell we are really tightly focused. Things are looking good. Sandy, everything looks great. All right, so I'm pretty happy with everything. That hand is looking great. Pop it up for me all the way straight up. Stevie's going to give you that water bottle. Go ahead, hold that up for me. Good. Now slowly bring it back towards your mouth. Good. Hold it right there. Hold it right there. Hold it right there. Hold it right there. All right. Put it back all the way up. Fantastic. That's looking good. Move your head to the side.
Look at you. Look at you. Cute.
I'm not shaking, rattling, and rolling anymore.
Good.
Look.
Dynamite.
After the focused ultrasound procedure, we celebrate with our patients. They complete their last spiral drawing and show off their new writing skills. We open a bottle of apple juice and toast for celebration.
Cheers.
Cheers.
To life.
Very nice. Ready for those
The
peas?
first time in years that I can actually hold a glass and drink without shaking. It's there's no words. Yeah. Yep.
All right, well, thank you, everybody, and that's what we're going to do for everybody.
Thank you so much to our incredible physician presenters today. My name is Kate Wayne. I am the Vice President for Philanthropy for our regional hospitals, which means I have the pleasure of getting to fundraise to support the work that these incredible group of individuals get to do every day. Philanthropy is often the bridge between dreams and reality. And one of the neat things is every single piece of technology that was talked about today, philanthropy played an important part of. Philanthropy has touched every aspect of Sharp Healthcare since our inception, and we are so fortunate that our community continues to want to invest in the work that we are doing each and every day to care for our community. Over the next decade, Sharp is investing over $2 billion in the future of healthcare in San Diego. And that's so important for a lot of reasons, but mostly because we care for more patients than any other hospital system in our community. And so we are continuing to grow to meet that need. And philanthropy is playing an incredibly important part of that. So our Envision campaign across all of Sharp is over $250 million. And here at Sharp Grossmont, that is $15 million to support the work in neuroscience. And so the campaign has been really inspiring to be a part of, partially because of the people of Sharp Healthcare. It's the people who are up here on the stage who continue to make a difference. It's our caregivers, who a lot of whom are in this room tonight, and then everyone else is back at the hospital working, who are continuing to make a difference in the lives. And our campaign is being chaired by longtime supporter Dee Yamin, and of course also with Dr. Razadeh. And because of lending their name to this campaign, along with the Grossmont Hospital Foundation Board, which is led by Christy Gregg, who is also here this evening, we know we're going to be successful in what we're doing because of our community. And so I am proud to announce that of our $15 million goal, we have passed the $12 million mark. We're not done, but we're getting there. As you've heard, the work is already happening and has been for quite some time. And the fact that we will have this building very soon, that this work will be getting to take place in, is just so exciting. And to think about where we've come since Valentine's Day and where we're going over the next several years is just truly incredible. So we will be opening this spring. We'll be seeing patients on the first floor probably in April or May. And so we have a party coming, certainly, to celebrate the incredible investment that's taken place so far. And so we're thrilled for everyone to want to be a part of it. If you're interested in being a part of it, whether it's philanthropy, whether it's getting more involved as a referring physician or a community partner, first of all, thank you for being here tonight. But please reach out to any one of us. And so we need to probably let this group get back to their patients who have been calling them all night long, and so we're a little bit over time. So I think we'll probably suspend our Q&A till afterwards. There's some refreshments, there's coffee and dessert out in the lobby. So if anyone has any questions, please feel free to come up to any one of us. But again, thank you to everyone who has been a part of this and who is going to be a part of this. And just thank you so much for being a part of this tonight. So that's it.